I'm Dmitri Gavriloff. I'm a sleep medicine specialist here at the University of Oxford and at the Oxford University Hospitals NHS Foundation Trust. And I'm a clinical psychologist by training, but as a specialist in non-respiratory sleep disorders. And I'm joined by Dr. Sophie West.
Hi there. So I'm a consultant respiratory physician, so with a lead role in the Newcastle upon Tyne sleep service, and I'm particularly interested in the respiratory sleep disorders, but I'm sure in both of our services we see all sorts.
Yeah, absolutely. But it looks like we're a good pairing because we cover all bases.
Yes.
I don't think we have a huge number of questions coming through in the chat. I hope that there'll be some that's filtered through. There we go.
What's the biggest advancement in sleep medicine in the last 10 years, in your opinion? I've read it out, so you can kick that one off, Dmitri.
All right. I mean, I think the thing is that the sleep medicine. This is a great question to kind of let's draw it out a bit, because I think that one of the things we might struggle with is filling the time if we're going to get a few questions dribbling through. There are lots of different areas of medical specialty, and I think that one of the things that's fascinating about sleep medicine is that it's a relatively new area. There's an awful lot to do in comparison with lots of other medical specialties. And I think that when it comes to what we do as sleep doctors, we're working at a very sort of the sharp end of the wedge. We're seeing people right at the top end of the spectrum. You'll get people in primary care who see all kinds of things, and we end up seeing people with very specific problems that are probably best dealt with by a specialist. When it comes to the developments that have kind of made things easier, there are lots of things, and they're not limited to the last 10 years that have made things much easier for us. But one of the things that I suppose is very useful for us, and again, not necessarily developed within the last 10 years, but is interesting to me, is being able to test people at home. So for a long time, we used to have to bring people into sleep labs, into sleep clinic, and they'd be kept overnight. And we still do that for a large number of our patients. But with steady advances in the ability that we have now to send people home and to do tests there, whether that's a full ambulatory PSG, or whether that's using actigraphy, whether that's using wearable devices, which are now more and more commercially available and cheaper and cheaper and cheaper. We're able to use technology, I suppose, in a way that aids our diagnosis or our assessment and diagnosis of the problem, and then can also influence treatment too. So I mean, it's not a particular development. I'm sidestepping the question very carefully here, but there is I think it's probably technology really that's enabled us to make assessments outside of the
and I'm going to add in, if I may, that I think there's been such an increase in awareness of sleep disorders in recent times, and a real interest in sleep. I think the evolution of Fitbits, etc., has given people a personal interest in sleep. We have, from the obstructive sleep apnea field, we've seen a real increased public awareness, increased GP awareness, so many more referrals to the sleep centre of these symptomatic people. One of the questions here said, tell us about some interesting cases in our respective careers involving sleep medicine. So I want to say that week on week in Newcastle and in other sleep centres across the UK and across the world, I'm seeing patients who have awful, severe obstructive sleep apnea, and often it's not been picked up for years, and they've been to GPs, maybe they've sought help from other sleep health professionals, or sorry, other health professionals, but it's not been flagged that this is fits with obstructive sleep apnea. So core symptoms of snoring, stopping breathing at night, unrefreshing sleep, and daytime sleepiness are those which go with obstructive sleep apnea. But if people slightly present them differently, like I'm very tired, or I'm I've got insomnia. They may all be due to core obstructive sleep apnea, but those symptoms may not be pulled out and people may not be referred for sleep studies. So this increasing awareness has sent more people to us. And the reason I flag this is because, as Dmitri says, we can do home testing for obstructive sleep apnea in almost everyone. We can set up CPAP as a day case. They don't come in. It's just a hospital appointment. People now have much greater understanding about CPAP as still the gold standard treatment for moderate and severe and increasingly mild sleep apnea. And I have seen programs on it and have friends on CPAP. And this is a life-changing treatment for people. And I love it seeing people back in the clinic going, I never knew I had obstructive sleep apnea, and this treatment has changed my life.
Absolutely. I think that these curative treatments for sleep-related breathing disorders are certainly not to be sniffed at. They are absolutely amazing pieces of very simple kit, actually, it's kind of in terms of the mechanics, but have a transformative effect on people's experience. So there's a question there about new treatments.
Yes.
And I don't know, Sophie, do you want to jump in with anything from the respiratory field? I mean, you guys have got stuff that works very well already, and you're kind of
I'm going to focus particularly on obstructive sleep apnea because that's certainly the biggest sleep-related breathing disorder. There's great randomized control evidence for CPAP CPAP was first described in 1981 by Colin Sullivan in Australia of 4 truckers who had obstructive sleep apnea, and he was really the father who invented CPAP. And since then, the basic principle of CPAP, which is a positive airway splint, is much the same, although the machines are more and more clever, smaller, quieter. And the machines now, we can get remote data so that we can adjust patients' pressure from our room in the clinic to their bedroom. We can see how they're doing each night, how they're using CPAP. So there are advances in that way, but the core concept of CPAP as an upper airway pressure is unchanged. And it's such an effective treatment that we think that slightly, perhaps over the past years, stifled other newer treatments for people who can't use CPAP or perhaps have milder sleep apnea. But there's been lots of interest in this area and some good randomized controlled trials. So groups in Europe, America and London, Jörg Stier's group, are particularly using hypoglossal nerve stimulation, either intrinsically with a nerve stimulator implanted in the chest or an external type device, a bit like a TENS machine, to trigger hypoglossal nerve to minimize sleep apnea and snoring. And that's very much an established therapy, but still an evolution about which patient group that will be suitable for. So that's one new treatment, and it's sleep physicians working with ENT surgeons who are looking at that. We're looking more at postural obstructive sleep apnea devices, so devices that you wear perhaps on your chest that buzz when you're lying on your back and make you turn over and try and train you to sleep on your side. And these, of course, are suitable for people with postural snoring or sleep apnea. It wouldn't be suitable for everyone. There's a big trial being led by Mary Morell and Julia Kelly in London that's going to roll out with centres across the UK to trial a single device for that. Drug therapy, that would be the holy grail, wouldn't it, of trying to find a tablet you could take to increase your pharyngeal tone and reduce snoring and sleep apnea. No, some signal, but not really a big area at the moment. I'm sure I've forgotten something, but I'll come back to it. Let me hand over to you, Dmitri, and you talk about your areas.
Well, do you know what? I'm going to do something similar to what you've done, Sophie, and talk about something that's there already, but is getting better and better. And so, if we think about the non-respiratory sort of correlate, I guess, of what you talked about, it's insomnia. So this is something that's affects up to 1 in 10 of us in the UK in adulthood. So it's something that's very, very, very common. And insomnia as a disorder is characterized by difficulty falling asleep, staying asleep, and maybe waking earlier than you planned on 3 or more nights a week. And it's something that is causing a death daytime function. So there's some kind of functional impairment. So it's something that at its diagnostic level is pretty extreme, and yet is experienced by 1 in 10 of us. It's a huge disease burden, if you like, and it's something that requires treatment. Now, up until very, very recently, this has been, I mean, I could have used this as my answer for the advancement in sleep medicine in the last 10 years. Up until about 15 years ago, we described it as being symptomatic of other stuff. This is really just your depression talking. You're actually a bit anxious. You should probably get that managed first. Or perhaps there's another psychiatric problem, or maybe a medical disorder. And insomnia was, you know, there were various subtypes. Insomnia was generally seen as secondary to other things. If you sort the depression out, don't worry, your insomnia would improve. And what we know from the experimental data and also from the wider clinical trials data is that actually the treatment that was developed for it, you know, 30 years ago, CBT for insomnia, cognitive behavioral therapy for insomnia, which is a composite treatment of several behavioral and cognitive techniques to deal with the problem, which is to say the people falling out of the habit of good sleep, or getting stuck in cognitive hyperarousal, periods where they just can't switch off. Dealing with these two bits, the behavioral and the cognitive piece, that treatment's been around for a long time. The problem is it's not being made available to people. So we have a treatment that we know works. It's very, very well tested. It's got an enormous evidence base and a very robust evidence base, but it's not available to the patients that need it day by day. So you can see that actually most GPs will see people with insomnia fairly frequently, and will have at their disposal really two things. They'll have a sleep hygiene leaflet, which we know most people will be familiar with already. So people with insomnia tend to be pretty good at their sleep hygiene. They've been online, they know not to have an espresso before bed. They tend to be fairly switched on. Or the other thing they have at their disposal is an FP10, and they might resort to prescribing something short term as a means of trying to help their patient in the short term. But what we know is best is this treatment, CBT for insomnia. So in terms of new treatments, we're not changing the treatment. We know the treatment works. We're trying to get that treatment available to people all over the country. And one of the ways in which we're doing this, interestingly now, this is part of the work that I'm doing through a company behind something called Sleepio, which is an online digital CBTI program, is trying to have something that's automated, doesn't require clinical involvement initially, and can allow the patient to go through this course of treatment, this course of therapy on their own, in their own home, in their own time, and to experience the benefits of it. And to talk about the benefits too, if you treat someone with insomnia and depression and treat the depression but not the insomnia persists. Because you have insomnia, you're at increased risk of a relapse into depression. If you treat the insomnia but don't treat the depression, one of the things we know is that actually the insomnia treatment itself can improve depressive symptomatology. So this is something that's worth thinking about in terms of the kind of the health economics of the whole piece. But it's also something that should be being made available anyway. People should be able to access the first-line recommended treatment. So the point really isn't that we're coming up with anything particularly smart here. We're thinking about ways in which we can make it available. And of course, it comes down to money at the end of the day. We're all, you know, the NHS, we struggle to make these resources available to people because it's we've got limitations placed upon us. So yeah.
I think the point you make there is very good about increasing access for CBT for insomnia, and very much we realised in Newcastle that lots of people were being referred for insomnia treatment, but you don't have the capacity within a clinic to do that. So it's been a real development, hasn't it, to be able to offer people access to the online tools via GPs or directly. How do you screen for other sleep disorders when you're recommending that for people?
So we just as you've said, Sophie, we don't provide CBT for insomnia as standard through our service. We can't. We just have too many patients to see, and we can't provide it in that way. So what we do is when we assess for insomnia, we'll do a full clinical history, we'll do a full clinical workup, and make a clinical assessment. And if we assume that it's insomnia, which it is very often anyway, these patients therapy. So we have a service to which they can go anyway. But if they do get through to us and through our clinical workup, as I say, clinical assessment, we determine that it is insomnia, they can then be referred by us, so we can kind of refer them back to GP, can refer them on. But one of the things I guess that's important and is kind of implicit within your question is we talk about sleep medicine and we talk about PSG. Very often the idea is, right, you just stick someone on a PSG, get all the information you need, do as many tests as you like, and then you can get some information about what's going on with their sleep and you can make an accurate diagnosis. But actually, relatively few people get through to having a polysomnography, to having this complex multi-parameter assessment of their sleep. The main tool at the disposal of the sleep clinician, the sleep doctor, is the clinical history. We go back and we make sure we have all we need to make sense of what's going on for that person. And if we need to do a bit more, we might refer them to PSG. Now, in Sophie's field, this is an area where overnight sleep studies or respiratory studies are, I would guess, after your clinical history, they're far more used perhaps than we would use in the non-respiratory side.
Yeah. And there's a couple more questions coming, but there's one about, has technology increased the efficacy of treatment? How do you feel about Fitbits and sleep monitoring? I think sometimes people didn't know they had a problem or didn't think they had a problem. Then their Fitbit might tell them they have, and then they come to the clinic to say, I'm worried about my sleep. But equally, and part of the treatment there that I adopt is sort of saying, stop looking at your Fitbit if you didn't have an issue beforehand. Yeah. How useful is it, though, in CBT for insomnia? I mean, often the advice is to try and stop looking at things at the night. But is that a technology that you think is useful, this sort of personalised trackers that people have?
So it's such a great question. I mean, I don't think we have a choice. These things are here, they're going to stay, and they're going to get progressively more and more accurate. I think, just to echo what you've said, Sophie, about patients that talk about their sleep relative to their readouts, if you like. I had a patient just the other day who was saying, I feel like my sleep's got so much better, but my Fitbit keeps telling me that I'm not. And I think, well, bin the Fitbit. Use your own intuition, use your own sense of how your sleep's, how you feel during the day, how you're functioning during the day as your cue for the sense of how you're sleeping. But I think so. I ran a study on this. We published it a couple of years ago in the Journal of Sleep Research, and we looked at patients. We took patients with insomnia, and we randomized them into two groups and gave them false feedback over the course of one night on their sleep using an actigraph that was set up to be a bit like a Fitbit. So they were given a watch, and the watch we told them would tell them the next morning how they slept, giving a sleep efficiency calculation. So they were primed with some information on what sleep efficiency is as a percentage. 60% roughly was not very good, 90% is very good, well done. And they were randomized into these two groups. During the course of the day, we were able to do an experience sampling methodology here. So we had them input into the watch, so a big watch with an input with a screen, information on their daytime symptoms using symptom measures. And what we found was that they did that throughout the course of the day, and then they came back at the end of the day. They did a symptom measure first, got the feedback, and then had symptom measures throughout the day, and then came into the lab. The group, as you might expect, the group that were told you slept very badly experienced markedly worse symptomatology than the group who were told that they slept very well. Now, the group who were told this, these are all people with insomnia, right? And they were randomized anyway, so any differences between groups are due to chance. But the fact that we were able to exacerbate symptoms in people through giving them this negative feedback, I think is important. Not because, these Fitbits are inherently unhelpful. It's that if there is feedback that comes back from these devices that is inaccurate, this could potentially, and I just emphasize the potential here, this could have the potential to exacerbate distress or some symptoms in people who might otherwise be all right had they not been so interested in it. Now, the converse is that if if you're getting good feedback and it helps you to feel better about your sleep, that you have a watch that corroborates that, then that's fine too. And it's not for me to be the arbiter of it, but it's just interesting research, I think.
Let's just change tack for a moment. Cal Howard says, how do you get into sleep medicine? Do you do a medicine degree and then specialise, or is there another route? I guess, like everything, there are many different routes. I can tell you how a traditional medical route is into sleep medicine, and that is a medical degree, and then you most people would specialise in either respiratory medicine as a speciality trainee, or neurology, or potentially anaesthesia or ENT. And sleep services in the UK probably are mostly run by neurologists or respiratory physicians, but not entirely. There are certainly anaesthetists, ENT surgeons, or physiologists running their service. But I'm privileged to work with a multi-speciality team, and I work with sleep specialists who are physiology trained, who are nurse trained, other psychology trained individuals will work within other teams. We're unfortunately not lucky enough to have one in our clinic with us. Anaesthetists often are more involved perhaps in the home ventilation, non-invasive ventilation side of things. So there are lots of different routes, but I think key probably is getting some good experience of a sleep centre as part of your training, and then working out what your route will be. But there's no one size fits all. So there are lots of different ways in. Dmitri, do you have anything to add to that?
It's very, very comprehensive. I mean, I suppose from a non-medical perspective, or let's say from a generic perspective, clinical training is deficient in sleep medicine, kind of exposure training. None of us, whether you're a psychologist, a nurse, a medic of whatever specialism, none of us get substantial training in sleep medicine. And as a result, the vast majority of us who get into it eventually have, as Sophie was saying, built up an interest in a particular area and then taken it off sort of later on. There's no reason why you can't start off by being very interested in it and developing it earlier on in your career, perhaps doing some academic research, looking into joining, a team at your university who's already specializing in sleep medicine research. But certainly one of the most important things is to read, to get into the literature, to become familiar with the terminology, the nomenclature, to understand the basic physiological processes involved in sleep-wake regulation and that kind of thing. The sleep medicine is all well and good when you've arrived at the top and you're able to work with sleep, but if you don't understand the basics of how sleep works, you don't understand the neuroanatomy, you don't understand the sleep-wake regulation processes, etc., then that stuff won't necessarily make much sense. So I think that don't wait to the end to get to where you want to be. Start as early as you'd like, as early as you can, and read. And they're great books. Like I'll do a bit of a plug here quickly. But fantastic book here, the Oxford Textbook of Sleep Disorders. But there are other similar books out there, books by the European Sleep Research Society, etc., that are great primers in sleep medicine and can give you certainly give you good grounding and priming in the field.
It's true, though, isn't it? It's very little covered traditionally at medical school, and I suspect that's similar across other health professional courses. So it's often something I certainly didn't do any until I was a registrar in Oxford, and then was delighted to discover that it was a field I enjoyed and was able to do research in. So certainly in the bigger centres, there will be a sleep medicine centre, and in many smaller hospitals, there will certainly be a sleep apnea service. So it's just a case of trying to find the one local to you and linking up with them if that doesn't happen automatically as part of your training programme. So we've talked about obstructive sleep apnea and we've talked about insomnia. I'm just going back to the other question about what interesting cases have we seen in our respective careers. Do you want to touch briefly on perhaps narcolepsy, Dmitri? It's always interesting.
Yeah, sure. So I guess it's important to understand the range of sleep disorders. When we talk about sleep problems, very often we default to this sort of societal insufficient sleep syndrome type thing. People not getting enough sleep or having disturbed sleep as a result of stress or whatever. But sleep disorders fall into 6 distinct diagnostic categories. So we have the insomnias, plural. We have acute insomnia, chronic insomnia, and insomnias that might be related to particular medical disorders. It presents very differently in children to the way it does in adults. There is Yeah, Thomas, if you'd like to, you can just search my name and search the study, I think. You have the sleep-related breathing disorders that Sophie's talked about. You have also what we call circadian rhythm sleep-wake disorders. These are disorders where there's some sort of problem typically in terms of the body clock and how that syncs to the world outside. And tends to be, a good example of this, just to come back to that question earlier about cases. One of the cases that we tend to see quite a lot in our pediatric clinic is what we call a delayed sleep-wake phase disorder, typically sort of seen as sort of lazy teen syndrome in inverted commas by the public, unfortunately. But it's not the fault of the young person. This is a person's body clock being a little bit later. They often struggle to fall asleep until very late in the evening, maybe as late as 6, 7 in the morning sometimes, and then maybe have to get up very shortly after that to get into school. And that's just a problem with their body clock not being aligned properly with the sort of normative schedules of the world around them. You also then get these, as I talked about narcolepsy, this is a group of disorders called the CNS hypersomnias. So hypersomnias are disorders of hypersomnia, of too much sleep or too much sleepiness. And Sophie's job involves differentiating between whether the excessive daytime sleepiness she sees in her patients during the day is a result of a respiratory disorder, or whether there's something else there too, from a neurological perspective. We also get disorders of what we call the sleep-related movement disorders. So sleep-related movement disorders include things like periodic limb movements in sleep, restless leg syndrome, and various disorders in childhood that are interesting, things like rhythmic movement disorders, etc. And so you have a real spread of different ways in which sleep can go wrong or can be problematic. Sorry, I've got a full house at home. And one of the things that's very important is to be able to